This program is brought to you by Emory University.
Doctor.
It looked a bit awkward, but she made a great point.
Hi, welcome back.
Hi, Jim, Vera.
Nice to meet you, Vera.
You were there yesterday, right?
My name is John Blevins, and I am on the faculty at the School of Public Health in the Huber Department of Global Health, and am currently acting director of the Interfaith Health Program there. We work on looking at the impact of religion on various health beliefs, health programs, health policies, and health behaviors, both here in the U.S. and internationally. And it's my good fortune to introduce the next three panelists for a second panel, which we're thinking of as a 30,000 feet panel, which is perspectives of people who were not directly on the ground responding to the epidemic in 2014, 2015, but people who have a background in public health research or practice and who can provide some context for the importance of the lessons learned from the Ebola epidemic to public health practice in general, and how to build stronger and more respectful and more sustainable community partnerships, and taking into role the importance of religious leaders. And then also to hear the perspective of someone who is not a public health researcher, but someone who is a family member of people who were living through the epidemic in Liberia, and who can speak from the perspective of a citizen of Liberia who was here in the United States at the time, and can offer perspectives of what it was like to know that this was unfolding in her home country, and that family members were daily living with the threat of Ebola, and what it was like to be here in the midst of that. So I want to introduce Vera Tarpa Keys, who is a friend of mine and my partners, who is from Liberia but has lived here in the United States for a number of years, and will speak on her experiences in the epidemic, knowing that family members were back at home dealing with it. And then Jim Lavery, who is the Hilton Chair in Public Health Ethics. Jim holds that chaired position just for what now, Jim? 4 months? 4 long months, having come from the University of Toronto, and joining us here at Emory. And Jim has been really valuable to me in some of my thinking and trying to put into practice some community forward and focused community engagement initiatives for some of the work that we do. And so I look forward to hearing his thoughts on this, both from the point of view of ethics and community engagement. And then Dave Addis, who's an epidemiologist by training and background and works with the Task Force for Global Health. And Dave and I have had a number of really powerful, informative and discussions for me with his interest in and passion in understanding and articulating the ways in which compassion is a practice and a grounding and a commitment that underweaves and undergirds public health and global health responses, but that it's something that people in public health don't talk about, and the importance of compassion to sustained and humane work, and the lessons learned from a public health and practitioner and epidemiologist, and someone who values the importance of compassion in that work, the lessons learned from Ebola from those perspectives. So we'll just go in the order here, and then we'll open it up for questions. Vera, are you okay with that? All right. We'll go in the order here that our panelists are seated: Vera, and then Jim, and then Dave, and then we'll open it up for discussion.
Okay, good afternoon. I'm Vera Tarpa Keys. The Tarpa is the giveaway for the Liberian nationality. As John said, I've been in the States for quite some time. graduated from Spelman College. I don't know if I want to date myself, but class of 91. And as far as the Ebola epidemic, I think it's sort of the way it filtered into the U.S. is sort of how it slow rolled into Liberia. Like, people weren't taking it seriously. I heard about it on the news and stuff like that. But when it hit, you know, I was on the phone. Mom, what's going on? We got a ticket. Get on the flight. Get over here. But in the U.S., they have a separation of church and state. In Africa, it's not so much. So even though, as far as government is concerned, they try to do that, but you know, there's prayer in schools. My mother is a woman of faith. I'm here because of her, I think, constantly praying for me, whether I know it or not. But so I was begging her, please come. This is getting scary. I need you to get over here. And she was like, well, we can't claim to be people of faith and not trust that God will protect us. So God wants for me to be here at this time, and that's where I'm going to be. Let me say that she was the Minister of Education at the time of the Ebola outbreak. So she was in charge of the entire school system of Liberia. And she told me initially, when it started filtering down through Guinea and Nimba, before it got to Monrovia, they started taking certain actions to try and protect the kids. But when they found out, you know, the messages weren't getting out as they should, as far as how to deal with Ebola, how to help families and students prevent them, as simple as washing, not doing the normal handshakes and greetings and stuff like that. She decided to close the schools down. And I believe she closed them down, and it was towards the end of the school year. I think it was May or June that she closed it down in 2014, and schools didn't reopen until February 2015. And she said it was, it sort of worked out because not only were the schools closed, a lot of government buildings were closed, so non-essential personnel were home, which means parents were home with their kids, which meant they could keep an eye on the kids to make sure they weren't or were paying attention to instructions as far as how to interact with people and how to stay at home. And actually, she said people came up to her after the whole thing and said they really got to learn to know their kids even better, you know, by sitting down at home with them every day. So she and her team were able to implement educational courses that they could air over the radio. So kids were not just at home and parents sort of going stir crazy. So they actually had school lessons for different grade levels. And everybody, well, not everybody, even the people in the further areas in the bush or whatever had radios. So these illiterate parents were able to sit with their kids, their school students, and actually learn stuff. So, and because it was from first grade all the way through, different lessons, different times. Now they had, prior to my mom getting there, implemented some storytelling times on the weekends for kids. And so she just took it a step further, and she said, well, you know, these kids are out of school for this time, let's just not have them sit. Let's get some teachers involved, get some lesson plans, put them out. In addition to lesson plans that were put out, they also put out information on how to prevent this. And they encouraged the different communities to, when they did interact with each other, they shared that information. Because the reason why Ebola spread so quickly, for one, a lot of people didn't believe it. There were some cases, unfortunately, in the religious communities where every religious sector has the wackadoos. And so there was a section that was saying, you know, this is God's punishment for certain things, for homosexuality, for disobedience, and stuff like that. And there were some evangelical priests who were saying, I'll pray it out of you. So people were going to church and staying in the church to be prayed over, and this spread. So if they're leaving during the week and people are coming on the weekends, church hasn't been wiped down, none of that stuff. And so people are getting infected even at church. It wasn't until the message was about a month in when the message really started getting in, and a couple of those religious leaders dying, that people realized how serious it was, and people started paying attention to, the warnings and how to prepare yourself and how to take care of yourself and stuff. My old schoolmate from high school in Liberia, she's a minister there now. So I asked her, I said, Debbie, did you guys stop going to church? What happened? She said, no. And she pretty much gave the same reason that my mom gave, we can't profess to have faith and then shut our doors to people in need. But what they did on their side, they had chlorine mats where people wipe their feet. So it's not just washing of the hands, it's wiping your feet before you enter the church. And the church has been wiped down with chlorine before service, and it's done again after service. So even though they did keep their church open, there were times when the attendance was low just because of the fear. So Debbie told me one incident, and I asked her about that. I said, was there any stigma in the neighborhoods? And she said one Sunday, I think she has like 5 kids, one Sunday they were going to church, and she had her niece with her at the time, and they were about to pull out of the yard, and the niece jumps out of the car and goes and throws up. And so everybody in the neighborhood was like, whoa. So she said what she had to do literally is take her niece back to her sisters, and just get back to the neighborhood and be like, no, she's okay, So it took them a while. I think she said about 3 to 4 weeks later, they found out the niece was pregnant. So that sort of smoothed things out. But, when that's happened, everybody like, Pastor? So that was one little anecdote that she told me, because it was after our conversation. I said, so what happened to your niece? She said, oh, she was pregnant. I'm like, okay. So there were even, I talked to another friend. She's a reporter. And she said, even though there were good messages getting out from the government, there were times where some newspapers were just trying to to sensationalize it. So they were copying whatever these ministers were saying. Oh, this is a punishment. Oh, this is a hoax, and stuff like that. That is sort of what, again, perpetrated the expansion of it. But again, as people started to drop, things get into focus real quick when you're talking about life and death situation. And I sort of was a little conflicted about that, because I was like, we've just come out, there's been 13 years of civil war and stuff like that, and there wasn't as much adherence. But I think the difference is, during the Civil War, they did not have control over that life and death. During the Ebola crisis, if they adhered to what was necessary, they had that control over life and death, over their own life and death, and over their communities. And communities got together and they taught each other, say, hey. And a question that I always had, I was like, so after this, what continued? Was there any protocols that were learned during that time that still go on? So my mom said that they still do the lessons for the parents. And a lot of parents actually came forward. So now they have continuing ed for the adults. They do it on the radio still, because there's still some people who feel self-conscious about coming forward, but they open certain centers to start doing that. People still have wash stations. It's not as prevalent, but there's, people still are washing their hands on a regular basis. People now, they greet each other, but when you choose not to greet in a hug or a touch, people understand. It's not an insult like it used to be, and stuff like that. So the last thing that I had was everybody, my mom, my classmate who's the minister, and the reporter, they all said it was a matter of education. Everything boils down to, the more you know. And because initially when it started, there were people making it a morality issue instead of a health emergency issue. Once people came to understand that it was a health emergency issue, then we could move on to the next steps as far as saving lives.
Thank you, Vera. Well, thanks, first of all, for the invitation. I think you guys dragged me into a meeting like that after I was at work for about 20 minutes on my very first day, and it's like, whoa, what's going on here? There's something. So anyway, and I think they've been just amazingly fascinating and helpful learning experiences for me since day one. So in terms of religious credentials, I think you guys have heard this story before, but I have like a fist-pounding Catholic grandmother, and my father, I think, was just like really afraid of her and ended up being a lot more moderate. And so, I had a very kind of moderate, like, well, it's the right thing, and this Jesus guy seemed like a really good guy, and just don't ask too many questions, and just, and now I have like an even more fist-pounding Catholic mother-in-law from Slovenia who was driven out of their home by the communists, and they left with nothing but their Catholicism, and so I get a bit of that as well. So she's kind of confused by me, so she would be really, really excited and a bit confused by me being here today.
We'll take a picture of you.
Yeah, exactly. Yeah. She would have some stuff to say about that, John, I'm sure. In terms of the Ebola, my involvement in Ebola was actually, I was a member of the Data Safety Monitoring Board for the STRIVE trial, the CDC Ebola vaccine trial. And just one thing about that was kind of interesting, that for me, I mean, my work is really very much about focused on communities and engaging communities and trying to sort out those issues. And so I like to kind of go and be on the ground and hang out with people and get into the villages. And what was interesting about this trial was that we didn't meet on the ground. In Sierra Leone. We met once in Brussels, and then we met every week for about 50 weeks by teleconference. And it was a back and forth discussion about whether it was safe, whether it made sense, and some logistical and cost issues as well. But it was kind of a very interesting remote experience for me, even though the calls ended up being incredibly well done and very productive. But I had another example I was a member of the DSMB for the Thai HIV vaccine trial, the RV144 trial. And we spent a lot of time on the ground in Thailand, at the sites, meeting people, and it was just completely different human experience for me. So that's just kind of a starting observation. So I just want to make a few quick points, but really they all stem, I think, from points that I think have been already described from the first panel, from Mohammed and Olusimbo and Dave. About social mobilization only being relevant when you need it, issues I think about the presumptuousness of behavior change. And I always say to students, just imagine some Canadian guy shows up at your door, knocks on your door and says, hey, it's really nice, you seem to be living well, but we'd now like you to just change. We want you to now eat way more maple syrup because we think it's way better. And we really want you to turn the thermostat way down because you're all too warm and that's just messing with your brains. And we'd just like you to do those. So you would just slam the door. But for some reason, when it's in other contexts, we just don't get too worried about it. And then this notion about speed and urgency and the impatience and this notion that there couldn't possibly be any time to do some of these more fundamentally human things. And I've been confronting this for a long time in my own work, but I thought those were really important. And I think, if you think about the counterfactuals there, what people are saying is it's too complicated. It is too time consuming, and time is money, time is opportunity cost for doing other things that are harder. This stuff is soft and it's kind of feel-goody stuff. And what we really need to do is not let that get in the way of the hard public health practice, clinical practice, delivery, performance of the programs, and the science, and the hard science. So these are conversations that I'm very weary of, but they are incredibly potent and they are persistent. And so I think that for me, one of the lovely things about hanging around with people like you guys is to have not only an appreciation that those things aren't soft and aren't irrelevant, but showing how incredibly relevant they are to the overall performance of these programs as well. So they're rare glimpses in, and I'm just really, really impressed with the stories. So when you come to, Dave's very stark language, not his language, conveying the language of this dead body management. And, when he said it yesterday, and I said to him again this morning, and like, how do you get it so wrong? I can understand being seduced a little bit by we don't have enough time and we don't really understand what happens and it feels fuzzy and we don't really know how to do it. I can understand that, but I don't understand how we can just get it so dramatically wrong to frame it in those ways and then to essentially prosecute a set of practices that reinforce that really awful, stark framing. And from the stories, that was done incredibly successfully. And it just seems so incredibly wrong. So, the question is, what's missing? Are the issues of training? Are the issues of socializing? Fundamentally, it seems to me that what we manage to do is just dehumanize or eviscerate the human dimensions of these activities that are fundamentally driven by people, right? And I think what we do is we privilege the framing, in this case, say in Ebola, in public health and global health sense. I think what we do is we privilege the framing of what I think of as the chain of transmission, and containment. We privilege those dimensions, and we disregard the deeper human interests and meaning that are attached to those kinds of activities. From one perspective, they're attached incidentally, but from the opposite perspective, they are the core through which those other things can only have any sense and operate. So this morning I posed this question to Dave because I have become a little bit seduced by management language. I actually I find it really exciting, and it's, as a kind of ethics guy, you're not supposed to say that, but I think a lot of it's really cool. And so one of my favorite expressions in management language is, what's your unique value proposition? And it sounds a bit jargony, but it's actually a really, really potent notion, and it's very difficult to respond to well, which I think makes it powerful. So here I'm thinking, what's the unique value proposition for working through religious communities in this type of activity? And so I want to take up your challenge, Dave, of trying to avoid spooky language, because I am one of those people that, even though I've grown up in a religious tradition. I think I've said that one of my best friends. It sounds like the start of a joke, but one of my best friends is a Jesuit priest, and my mother-in-law loves him to death because we have kind of family relations. So I would say, I'm hanging out with Rob. Rob's kind of, and she's like, oh, thank God. So I'm not trying to run away from these kind of religious notions and religious traditions, but they're not really my day-to-day kind of. It's not where I start. So in non-spooky language, here are just a few observations about where I think some of the unique value proposition lies. One, I think, is that, and you'll see that these are kind of additive. The one is that there's a kind of convening power about religious communities that's very unusual in terms of its scope. And that's great for a whole bunch of reasons. But, and I won't get too anthropological or ethnographic or anything, but just a bit more pragmatic, but it's really a great thing if you want to deliver messages, if you want to tell people stuff. Where I just don't understand as much, because I come from a Catholic tradition, is how effective the convening is for listening to people. Certainly in Catholic tradition, listening's not such a big deal. It's like, yeah, you guys kind of stay quiet. We'll do the stuff up here, and just trust us. Everything's going to be good. So the convening power, I'm not as sure about how well that affects. It's partly behind my question about what the dynamics are like. What are those leaders learning from the congregations, from their communities, in the course of these transactions, these encounters? So that's something I'm not sure about. But this convening power for me is number one. The second point, and this kind of maps back to the way that we think about our model in community engagement, is that these religious communities and the leadership, the affiliation, it's what I call a very robust representation of interests. So let me unpack that for a second. So religion is even more than politics, although some may question that in this country, but it really does kind of provide a comprehensive worldview account of life, where you fit, how to make sense of your life, probably more than anything else. And it encompasses all of these things that really, really matter about you and your relation to the rest of the people around. So part of what we try to do in community engagement is understand what interests are at play for various stakeholders. And if you're having small-scale stuff, you can do that on an individual relationship level. When you have to go to scale, getting fair and reasonable representation of interests is actually very difficult to do in a more political sense. So there's something unique about religious communities that deliver up a kind of comprehensive claim of representing interests, which I think is really unrivaled. So, just to unpack that one step further, it seems to me that the worldview, the interests that are dealt with and reflected in religious communities really are fundamentally about that human experience that I was just claiming gets eviscerated upstream. So notions of of caring and compassion and notions of other regarding type behavior, I think they're central to the core notion of the interests that are represented in those religious communities. And again, I think that those are partly the things that we yearn for in more secular approaches to these things. We want people to be caring, we want them to be compassionate, we want them to be other regarding, but it may be that they don't come from the same natural worldviews that are going to reflect those things as potently. And then the final two pieces is that there really is this kind of social network of relationships that exists within religious communities. And I think one of the things that I've just found most fascinating about hearing Dave's story in particular is just I also love Dave's terminology of this catalytic process whereby constructive engagement with different religious communities can also help those communities develop their own engagements and further their own kind of relationships, which I thought was just really fantastic. So there really is something incredibly important about these relationships as part of the communities as well. Again, that if you're thinking about things at scale in global health or global development, I think that's just absolutely critical. And then finally, the last point I'll make is that it's some of these kind of unique elements that I'm saying might form part of your claim to a unique value proposition that really are precisely the kinds of things that are hardest to replicate when you're doing this under the guise of a program for the Gates Foundation, which is where I do most of my work, or other funders or implementation partners that don't bring the same kind of worldview. So for me, what's been so instructive about hearing about these stories is just how can you take some of these core ideas and import them into more secular strategies without using spooky language.
Thank you, Jay.
Thanks. Well, it's great to go last because it's basically already been said. So
Yeah.
I can point to some things that I've heard and also maybe add a few comments. Mohammed's representation of community mobilization as the sort of spare tire reminded me of a passage from a book by Henry Nouwen and Don McNeil and another author whose name I can't remember. The title is Compassion. And these three people went to visit Hubert Humphrey when he was, I believe, a senator. It might have been when he was vice president. And he had just come from some tension-filled meeting, and invited them into his office, and they sat down and they asked him if he could comment on the role of compassion in politics. And this really flustered him, so he got up, went to his desk, and fiddled around with a pencil and came back to the table and said, "Well, gentlemen, compassion is like the eraser on this pencil. Most of the time, we pay no attention to it, but when things get bad, when the tire's flat, we pull it out and try to correct things." And I say that because this came to mind because is compassion something incidental, to use your language, Jim, or is it actually the core that drives this whole enterprise of global health? And you can look at it from both ways. I think that Ebola shed a light on both the virtues of global health and the deep values that we hold as a community, and also the ways in which we still have to live up to those values. There was tremendous suffering, and there was also, as I was not involved in the outbreak response, but just observing it, I saw tremendous compassion on all levels. There was a performance artist, Steve Ben Israel, recently died, and in the obituary that was in the New York Times, it said his life's work was to foment a mass uprising of compassion. And I think global health, in a sense, is a mass uprising of compassion, and we saw such a mass uprising in the face of Ebola. We saw this in the response of hundreds of healthcare workers and the millions of acts of kindness of people who were affected by the outbreak on the ground. And we even see it in scientific publications. In New England Journal on Ebola, you see footnotes in the memory and honor of colleagues of these authors who suffered and died from Ebola. That's unusual to see that in scientific publications. So it brought a sense of solidarity, of human dignity and compassion. It revealed that these are values that we hold. But as John mentioned, in global health, we don't talk about compassion. We don't talk about our motives. These are things that are too personal. They're kind of squishy. We don't think they're science-based. So we talk about social justice. We talk about health equity. And we focus on the macro level. We don't want to get too personal because there's so many needs, and we work through systems, and we work through big ideas and big programs. And with that macro focus, we tend to ignore both our inner selves as well as our close others. But the motivation, in my experience, talking with hundreds of healthcare workers, global health workers, is that for many people, the motivation to care about social justice is really a deep sense of compassion and solidarity. It's something very personal. It comes from a sense of deep interconnectedness, not only with the people we're close to, but with all humans. And that's essentially a spiritual value that is taught and passed forward by the religious traditions. Karen Armstrong, a scholar who studied the religious traditions, points to compassion as being the one thing that is common to all religions, and that it lies at the heart, that principle of compassion lies at the heart of all religious, ethical, and spiritual traditions. Psychology has looked at three components of compassion that essentially required elements. And I think all three of these were stressed in the Ebola outbreak. The first is cognition. You have to be aware of suffering. You have to recognize it as suffering. And certainly in the early days of the outbreak, it was very unclear what was going on. There were rumors. There was suffering, but it was way over there. And yeah, there had been a few Ebola outbreaks before, but CDC had handled those. And so it wasn't really, except MSF was the only group that was internationally saying there's something going on here. We didn't hear that signal. It was very hard for us to understand the faces of the suffering that were being pointed to. And there was denial, and there was this distance. The second component was of compassion is an emotional resonance. We have to resonate emotionally with the suffering other. There's an empathy, which is this emotional resonance. And this was challenged on so many levels. I talked to a nurse from Emory who participated in the response, and she described not even in full of the suit, protective suit, not being able to hold a child while the child died because of the risk of contamination even through the suit and not being 100%. So it was hard to express compassion, this need for isolation that has been mentioned. The fear, which is a very powerful anti-compassionate agent. And then there was this whole issue of emotional regulation. When we want to be compassionate, we have strong empathy, especially in the place of extreme suffering. When we're unable to relieve that suffering, it often then becomes our own personal distress. And we get into a fight, flight, or freeze response, or we get really busy and we try to alleviate our own distress through action that may or may not help those who are suffering. And this was so intense for so many people, both who were residents of these countries and those who were sent to help. So that proper level of emotional regulation to be able to stay in the face of suffering even when you couldn't fix it. We didn't have the experience and the training to maintain that level of emotional regulation. And then the third element of compassion is action. And this is where it differs from empathy, and that empathy is the feeling, the emotional response, and compassion involves the action. And here again, it was challenged. As Dave was saying yesterday, the systems were very much stressed, and it really wasn't clear what to do. And there were so many things that needed attending to at the same time that the action initially was ineffective. I think there's some lessons here related to compassion and to global health and to the faith community. I think in my reading of the Ebola experience and the outbreak, the centrality of compassion to global health was reinforced in me. But how do we cultivate that in ourselves as a community? How do we prepare for it? How do we nurture it in the secular field of global health? And I think this issue of looking at compassion as the core or the incidental is also influenced by our continual focus on the macro and systemic solutions. We're not looking at inside ourselves or to our the human dimension. And I think the Ebola outbreak has implications for global health ethics. And we need not to just look at IRBs and systems, but we also need to look at the human dimension, to see the faces, as Bill Foege says, and how do we bring that into an ethic of global health? I think it also has implications for the role of these spiritual and religious communities in cultivating compassion. Many global health people are motivated, they're members of spiritual and religious communities. And I think it's not a coincidence, I don't think, that the values of global health read like Catholic social teaching or like the core values from the religious texts. So how do we as members of faith communities and as global health people, what's the role of nurturing and deepening our compassion? What's the role of the faith traditions in which we're members of, and of this profession of global health that we're a member of? And then how do we understand and embrace these spiritual foundations of global health, and how does that prepare us to respond more effectively to the next outbreak? So those are my thoughts. Yeah.
So before I open this up for us in the audience to ask questions and to begin a conversation with the three of you, I just wanted to first give you a chance to respond to each other. Were any things that any of one of you said that you wanted to respond to as you went down the road?
I was saving my questions for dinner after.
We get the chance to have dinner together, so Vera's going to ask her question at dinner. All right, so we'll open it up to the audience in general. Again, if you would come up here to ask your question so that we can record it. If you have a question for this panel.
I have struggled with the role of compassion in global health for a while. When we first, and when I say we, I mean UNCOR and Global Ministries first moved to Atlanta, we're going around visiting our neighbors, and we made a stop at Global Health Task Force. And I met with the CEO then, and he drew this, we're having this conversation, and he drew these 3 circles on his whiteboard in his office and said, health started here with compassion. And over time, we moved all the way here, and it became all about business. And now we're trying desperately to connect those 2 circles together and merge the 2 in some intersection in the middle. And I think that is one of the things we struggle with right now for those of us who work in faith-based organizations. When there's a perception that we've moved away from that compassion and that motivation of compassion as people of faith or representing a faith community in our work to just being vendors and say, yes, we go after the money, or there is a publication or a notice out for funding, and we go after the funding. And the feedback we're getting from the community is they're not sure now why we're doing this. Are you doing this now because there's money to be made? Or are you doing this because you really care about us? And I've seen that play out, in Haiti and in Sierra Leone. And, when Dave was talking about the corruption and all of that, we then begin to see even those of us who are faith communities just going after the money. And people on the ground can sense that because they don't really see themselves benefiting from a lot of what is going on. How do you explain how many billions of dollars spent on Ebola? The hundreds of vehicles bought, the millions spent on building the tent. But now, if you go back to Ebola, I'm not sure the average doctor in the hospital can follow the Ebola protocol. Because when that happens again, we'll then need to ship the US Army and ship in 20,000 people from outside to come respond to it again. And people begin to wonder, is this out of compassion for us or out of fear for yourself? Or out of, a business? And disaster is good business, for a lot of people. And those are some of the struggles that we have, and how do we become more intentional in communicating with people without engaging them, without letting them know from day one the transparency and say, this is how much is involved in this and this is what we're doing with it. And without that transparency and that intentional engagement of the community, people begin to question our motive, even for those of us who are from the faith community. Even when we bring the same exact intervention and say, we're driven because we feel compassion or the love of God constrains us, and these other people are driven by them. They can't make that distinction because it's less and less clear who's driven by compassion and who's not.
Any comments from the panel?
Let me take a quick stab. I think this is probably a little bit more in Dave's sweet spot, which is a good way to say it. My answer may not be very good, but I think one of the challenges is that it's never either or. It's either compassion or you pursue your business interests or your organization's interests within the kind of system that we have. Joanne Lynn, who was an end-of-life care specialist years ago, she had this saying that I just love, and it's that we have a system that's perfectly designed to produce the results that it produces. And I think that what happens is that I think that there really is, I think, some kind of fundamental motivation, some self-selection, if you like, in a lot of people. I mean, you certainly see it in global health, even public health, in these areas where I think people really want to do good. I see this with students all the time. They show up, they want to save babies, they want to do this stuff. And part of, I think, what we need to do as educators is to help them understand that it's really ugly out there, and the ministers of finance don't care about health. And they're all men. You may have ministers of health that are women, but you want ministers of finance that are women, and they don't care about health. And it's partly that whole, understanding the nature of the system and its warts and ugliness as well. But I think that the other part of it is that we don't do a good enough job of sort of calling these moments out. So I'm years ago I got initially kind of sucked into sitting on the bioethics advisory panel for Pfizer. And in my field, that's like going to the dark side. And it was, it's like, I talked to people, they're like, oh, you can't, it would be a career ender for you. And I thought, but like, no, no one's talking to these guys. Like they're, so anyway, I've been doing this. But so during Ebola, and we bring 50% of the agenda items and they bring 50%. So during Ebola, I had an agenda item in our meeting in New York, and I put up a slide about what was known at the time about the consortium that came together for Ebola. Just as you said, all of the money, all the mobilization, all the changes in business practice. We're going to share this. We're going to share that. We're going to make this faster. We're going to do all this sort of stuff. And then this is Pfizer's contribution. And then I put up a slide and said, this is basically the table of the mortality table of diseases and their contribution to global mortality. And you go 3, 4, 5, 6 slides. Ebola doesn't show up. It's not on any of those tables. It's way, 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 way down. Super dramatic, terrible, terrible. But it doesn't show up. It's like, are you feeling motivated about tuberculosis? Right? Are those same intuitions about that may be generated through some core of compassion? Are you willing to change your practices about that? Tuberculosis is a great example because it's the classic public health failure. It's probably the disease that we've known more about than any other disease in the history of the human race, where we've had perfectly curable disease, and we've turned it into an uncurable disease. So I think that there's a lot of stuff going on. There's always the overlay with these different kinds of interests. The systems are flawed, and when things like this happen, we don't treat them as moments to say, look at the paradox you've created here. You're ignoring. So I think that that's something we can do as teachers, and I think as a community, we can try to call those things out a little bit more. And as I always say to people, if you really want to have an impact, write something in The Economist. Don't write for each other. Like, we already kind of get it. Like, write for ministers of finance and tell them why they should be doing this. Sorry, I just keep going on. Like, this now because we've been hanging out a bit, but yeah.
If I could add a couple words to that. Thanks for that comment, because I think it's so poignant, and it's something that we as a community are really wrestling with, I think. And again, I think Ebola shined a light on our virtues and also shined a very spotlight on ways in which we have yet to live up to those. To what extent has the global health agenda been compromised by initially several years ago, 9/11, when we were, in my view, CDC became a civil defense agency for several years, and we have this now global health security, and it's essentially a fear-based worldview. Well, that does motivate mobilization of vast resources, and certainly that can motivate resources to be, good can come out of that mobilization of resources. But it's not the mobilization of compassion, and you've pointed your finger at and you put your finger on this dilemma. What was behind my question to you in the first panel is, how do we as public health people get so enamored of our interventions that we essentially forget about human dignity, and we forget about what we would want for our loved ones? There's this human dimension that we just we forget it. I think there's a role for the faith-based organizations and faith-based individuals in global health to remember that and to stand up for that and to say earlier on, no, this is not acceptable, because in a prophetic way, calling the rest of us to a compassionate and humanitarian response. We so easily forget that I think that prophetic voice within global health, the place where that's most likely to come from is the people of faith and the faith community. Because you're reminded and steeped in these values in an intentional way, that way the rest of us may forget them in all the programmatic and structural things we're dealing with. So I think there is a role, and it's a prophetic role, and it may not be always discernible from all the other organizations or all the other people, but I think there is a prophetic role of religion in these types of responses and of religious people.
As a layperson, you know, it was wonderful to see the response as far as Ebola stuff going there, getting the PPEs, the personal protective equipment, and all these supplies. And, you know, I think I almost did a backflip when Obama announced that he was sending troops. I'm like, woohoo! You know, but as you were saying, as grateful as I am and we are, the Liberian people and people impacted of the help, you know, and I'm not even sure if it's the role of the global health faith community, but it's like after, you know, is that religious thing where as I spoke to John, you know, teach a man how to fish, because you've helped us, you know, we've learned how to take care of ourselves in certain aspects, but now you're gone. You know, we have these buildings here that either people are not going to use because of the stigma, or they're going to use it but not for the purposes intended. So where does that part of the contribution come in, where you know, you don't just swoop in and help, okay, you good? Okay, we're out. Like if you just leave a ground party, like, hey, we're going to keep teaching you guys. Here's what you can do to maintain this, or here's what you can do to help get your youth involved in the health sector. Let's set up some training programs. You know, 50 doctors for a population of 4 million. Okay? When I say it, the tears come to my eyes. I worry about my mother every day. And during Ebola, I mean, I called her regularly on Sundays after church we'd speak, but I was calling her every day. Did you touch anybody? Are you okay? Are you home yet? You should be home by now. You know, because they sent non-essential people home, but she was still going to work. You know, I remember calling one time and somebody answered her phone. And they were like, hold on, let me go get her. And she gets on the phone. I said, what the heck? Somebody's touching your phone? You know, what is wrong with you? You know, so, you know, the fear, you know, and feeling powerless over here to help, but, and being so appreciative of what they did, but it's the after effects. They're gone now. They are keeping up, you know, they're doing the lessons and the radio stuff afterwards, but how are they helping the people to learn? How are they bringing the youth in? And I think that's part of, you know, as a layperson, that's the kind of stuff that I look at afterwards. You know, that after impact. Yes, you guys help, but who or who do you turn us towards? Or is there another consortium that we need to, you know, focus, you know, this is our portion of it. Now move on to the next step. But who do we engage to get that with the whole, you know, community involved?
Can we get the whole group up now? I wouldn't mind that. I'm sorry. Because I think they might want to talk to each other, and then if you wouldn't mind, like, because we've just got only 15 minutes left, you just pull some chairs up here and get everybody up here.
Your mom sounds like she shouldn't be messed with. Eh? Oh, yeah.
Okay, good.
And this is perfect, because one of my question is, and adding on to what you've just said, is the mental health piece. So not just what happens next and engaging people, but there was a wasteland. I mean, I don't know how many physicians were killed or died. And, young people who lost parents who lost children. I mean, what happens to them in that afterthought too?
Yeah, I actually asked my schoolmate, Debbie, who's a minister, and I did ask her about that. I said, how did you deal with these people with their, the mental health of, even if you weren't directly impacted, the trauma and fear constantly of the possibility of being impacted. And she said there were groups like the Red Cross that worked with the religious sector and trained some of the religious individuals to counsel people, to talk to them. But it wasn't a lay person, it was more on the religious side. So even then, it was still, the impact was still minimal, because if you didn't go to the church to get it, you weren't getting it. So, and if you don't go to church, then, that's an issue. So yeah, that is, even continues to this day, something that needs to be looked at.
It's really remarkable how resilient human beings are. These two countries, and Guinea even, are countries that have suffered so much. Years of civil war, one thing after the other, that sometimes you begin to think that people, I don't know where they get the strength from to just keep going on, but people have now become used to living a day at a time. And that is a struggle that we continue to face in terms of motivating people to aspire for more or to invest in more. And I'll give an example. How do you convince someone to use a bed net and protect themselves from malaria when they don't have food to eat? It's like, I'm going to die of hunger now. You're telling me to protect malaria in the future? So these are lasting effects of repeated exposure to such traumatic life events that people have lost the zeal almost to aspire for more. And we're working with some of the doctors and young people, giving scholarships for medical training and education and all of that. And sometimes it's so hard to even get enough people to be interested in that. Most people want quick wins. It's like, who has time we want to make money now and maybe we'll not be here tomorrow. And engagement with the religious community has been the mainstay, and that's why you see religion play such a central role in these countries, whether it's even at the height of the crisis, people will still seek out religious, gathering, at the risk of their lives even, because that's the only thing available. There are no counselors, there are no therapists, and even the religious leaders, unlike here where people have masters and have chaplains and all of that, they're just people, for the United Methodists, most of them are lay ordained ministers, because that's the only thing that's available. So just a little brief training on psychosocial support and how you can continue to support your communities through this trying is all they got. But they were giving it all they had, because that's the resource they have available. But like you, I continue to wonder how people, the resilience of the human being, and they just continue to go on. Sometimes you don't know how, but they do.
Well, I was going to say, one of the things that struck me in your talk yesterday too, Dave, was the text messages that got sent around with these, they were kind of scripture,
right.
Quotes from scripture, and they were really meant to be kind of motivating and sustaining messages. And, I think I mean, I'm not going to make any claims about the impact on mental health, but it seems to me that one of the things, again, that's unique in religious communities is that there are these kind of governing narratives that are outside yourself and that you can situate yourself in. And so I think there's something so critically important, especially at those times of real crisis, about being able to say, okay, I have my experience where I'm feeling it right now, but I know how to situate myself in a broader narrative, in a narrative that includes, that's intergenerational, that's kind of that's universal in a sense. And my guess is that would have, if you could do that genuinely and feel that genuinely, then I have a feeling that that's got to have some kind of protective effect. I mean, whether or not that's going to solve the kind of traumas that I've experienced, that's a different question, but that must have some kind of protective effect, I would think. Yeah.
I had a question from Mohammed on this. The text messages prepared by the United Methodist Communications, Bishop Yambusu, were really aimed at a Christian audience. Mm-hmm. World Vision, we discovered it, we bought it in for our Christian staff. One of the challenges we found with the burial teams, they were mixed faith teams.
Right.
So, and one of the requests we started to get from the burial teams was we had the channels of hope. Mm-hmm. We had all these, this kind of spiritual nurture of staff for the Christian staff, but we couldn't find the resources for the Muslim partners on the burial teams. And we began to notice the psychosocial needs of the burial workers who were really seeing the horrible, cutting edge, the ugly edge of going into people's homes, being on the receiving end of stigma. They couldn't find restaurants that would feed them. They couldn't find rooms where they could sleep. They were rejected from their own families. And this sense, and it just went on. It went on for months. So the heaviness of this exposure, we were hearing stories of nightmares and trying to get days off, trying to hire more people so people could get a day off. I mean, we had to negotiate with the donors to give us more money so we could basically sustain the coverage. And there was the psychosocial trauma issue, but we didn't have resources from the Muslim community in the text message format. So we didn't actually make it available to the burial teams because we didn't want to discriminate. Right. I mean, as far as I know, you're the only Muslim at the table here. Help me understand the multi-faith dimensions of dealing with this when the Christians are putting all this effort into spiritual nurture of the Christian staff, partly because of the systems and the global denominational stuff. Give us some feedback on that. I'd love to just hear the reactions you heard, if any. Was there any expectation that Muslim burial workers would get that kind of support?
I mean, I'm not sure if I can, well, my name is Mohammed, but how do you know I'm Muslim? That's the question. I am Muslim. But
I know your family.
I was like, wait a minute. Did you look me up? How did you confirm this?
Comedy there.
Let's say you're closer to the reality.
And something else I should mention, I think in Sierra Leone, and I'm not completely right about this, but I mean, there's a lot of interfaith collaborations. We even have like a slang called Christmas. There are people who say they're Christmas. On Friday they go to the mosque. On Sunday they go to church. Christians get married to Muslims, and they first go to the mosque. They live there, and everyone comes to the church. We actually had a family friend who's Nigerian and came from the northern part of Nigeria, very conservative, and they came to Sierra Leone, and they were so confused by the notion of Islam in Sierra Leone. Said, "Are you guys sure you're really Muslims? Like, what is going on? What is going on here?"
That's true.
So I mean, I think the message is it depends on how they were framed. I think could have been accepted by the Muslim burial workers, my own concern with the messages in general, with the text messaging, because I know some of the burial workers also didn't have high literacy skills. I'm just wondering their ability to be able to understand those messages, and then sometimes, for me, I don't know, like if I'm in a very bad place and then I get a text message, it may help. It depends on just where I'm at. That's just me. I don't know about someone else, and I think the one-on-one interactions, also that they had, but sometimes they're coming from a very powerful person like Bishop Yambasu, who you respect a lot, and you're not expecting it either, right? And then you just get this text message, would be very powerful. I think the same could have been done. There are very well-respected imams in the country that, some of those messages could have been used, and just make sure that, as long as people don't feel like you're not doing this to try to convert them. So I think Muslims and Christians get along very well, except when in Sierra Leone, except when they feel like you want to start converting and doing that kind of stuff. Then that's when sometimes there's a lot of the pushback. And there was something else I was going to comment on. So the mental health piece is very, very important. And, and for me, this issue of resilience, sometimes, I question it because, it's kind of a way of, and I know this is not what you were doing, and I'm very interested in resilience as well. It can almost kind of just say these people are tough, they're strong, and they can handle it, and they can absorb a lot of this pain. But the truth is that people sometimes, they just don't have a choice.
Right.
So I don't know if it's resilience or sometimes not just having a choice. And a lot of times, I asked my dad, I was like, I don't understand why we don't see so much mental health problems in Sierra Leone because of all the suffering that's going on. And he was like, well, it depends on how you think about it. A lot of these people in Sierra Leone, he said myself included, because, he lived most of his life there. I lived there, but I moved to the U.S. He said, people are comparing bad with bad many times, right? So if you don't know what good is, it's kind of like a dark place when you think about it sometimes, right? Like you don't know what's good, so therefore, when bad things happen, sometimes you don't even recognize it as being bad because a lot of what you see around you is just bad. So bad is kind of like the norm. So, the normative atmosphere around you is kind of bad. So much that when you see bad, it looks like good. And it looks like whatever it is, and you don't know what to make of it. So I think we got to be very careful when we talk about resilience, because, we actually did a national survey, very robust, in July 2014, where we decided, we're doing these CAP surveys to look at knowledge, attitude, practices, but really we should be looking at mental health also. So we decided, and I advocated for this very strongly, and we got some mental health experts from CDC that we collaborated with, and we were for the first time able to measure national prevalence for anxiety, depression, and PTSD in the middle of, about a year out of the outbreak. And we actually found really high levels of symptomology for anxiety, PTSD, depression. For anxiety and depression, 50% of respondents had one or more symptoms for anxiety, depression. PTSD was about 75%. But in terms of clinical levels, that's quite different. So symptomology does not equate to clinical levels. For clinical levels, we saw close to 10% for anxiety and depression, and then about 16% for PTSD. This is really high for a national level prevalence of possible clinical levels of anxiety, depression, and PTSD. So, I know we're having these conversations about resilience, but, our data that we have, and we also looked at it from people that had some Ebola-related experience, and we saw that if you had some Ebola-related experience, such as knowing someone who died from Ebola, or someone who was quarantined, or even knowing someone who survived Ebola, you're more likely to be at increased risk of PTSD, anxiety, or depression. Which shows that Ebola definitely had a mental health impact, and it's a paper that'll be out very soon, and you'll learn more about it there.
I feel like we could carry this conversation on for more hours and it would not get less interesting, but we've already imposed on you a lot this afternoon, so I want to just get one more round of applause for